Good evening, everyone. Welcome to Second Opinion, Integrating Novel Approaches into the Management of Non-Muscle-Invasive and Muscle-Invasive Bladder Cancer. Dr. Terence Friedlander, and I'll be moderating the meeting today. We have our faculty, our esteemed faculty here today. To my left is Dr. Matthew Galsky from Mount Sinai. Next to him is Dr. Andrea Necchi from Milan, as well as Dr. Shilpa Gupta from the Cleveland Clinic. In order to make the meeting more relevant to participants, Dr. Love conducted video interviews both with Dr. Betsy Plimick as well as with Professor Tom Poles, during which they presented cases from their practice. And so what we're going to do is show excerpts from these videos to sort of generate discussion, I think provocative points, interesting topics for discussion. And they'll come sort of through the evening tonight after each one of our talks. Here are relevant disclosures. And here's our commercial support. The Research to Practice CME Planning Committee members, staff, and reviewers have no conflicts to report. I also want to point out that this is an educational activity, and we may discuss non-FDA approved uses of agents and regimens. Please refer to the official prescribing information for each product for its approved indications. So tonight, as I said, we're going to be talking about novel practices in non-muscle-invasive bladder cancer as well as in muscle-invasive bladder cancer. There's really a lot going on in this space and a lot to unpack, and hopefully we'll be able to dive into some of the major questions that are facing the field today. This is our agenda. We're going to have 4 modules or 4 talks. I'm going to lead off talking about the use of anti-PD-1 or PD-L1 antibodies in non-muscle invasive bladder cancer. There's some pretty exciting data that's come out just in the last year. Module 2, Dr. Gupta is going to talk about muscle-invasive bladder cancer, where we stand today and maybe where we're going in the future. Module 3, we're going to look at intravesical therapies with non-metastatic urothelial bladder cancer. Dr. Necchi will discuss that in depth. And then Module 4, we're going to talk about cell-free DNA, which I think is also a very exciting topic, and Dr. Galsky will focus on that for non-metastatic bladder cancer. So to start off, I want to talk about the sort of rationale for using PD-1 therapy in combination with BCG in the frontline treatment-naive high-risk NMIBC patients. We're going to look at 3 phase 3 trials, the CREST study, the Potomac study, as well as the ALBAN study. All of these were presented just within the last year, and we'll talk a little bit about future directions. So I think most people know that BCG is the standard of care. It's been the standard of care for about 30 or 40 years at this point. And while it's effective in reducing bladder cancer, in eliminating bladder cancer, for patients who have intermediate or high risk, as you can see in the curves on the right, there's actually a fairly high recurrence rate. Patients with high risk or very high risk disease, almost half or more than half of them eventually recur. And so there is an unmet need in the frontline space to improve therapy. To date, we've not had any therapy that's beaten BCG in almost 40 years. So why should we add PD-1 therapies? Well, I think there's sort of 2 ways to think about this. Immunologically, we know that BCG, when it's given, actually upregulates PD-L1 on tumors and also on tumor-infiltrating lymphocytes, and that suggests maybe these antibodies would be helpful. BCG-resistant tumors also have higher levels of PD-L1 expression, and resistance also associated with T-cell exhaustion. So there may be a role for further stimulating the immune system to get a better effect in the frontline space. And then clinically, I just said there's an unmet need for better therapies in the frontline. If we can cure this, we should just cure it with the first therapy we give and not have patients coming back for years for multiple other therapies. And then there's this idea of sort of a synergy between these therapies. BCG is given into the bladder and may eliminate or help eliminate localized disease, but PD-1 therapies are systemic, and perhaps they can address micrometastatic disease, disease in the muscular wall of the bladder, disease in the lymph nodes, and elsewhere. So the first study I want to review is the CREST trial, which looked at sasanlimab in BCG-naive high-risk non-muscle invasive disease. This was presented first at AUA back in April and then updated in ASCO this year by Dr. Shore and then Dr. Poles. So sasanlimab is a novel IgG4 monoclonal anti-PD-1 antibody. It's given as a subcutaneous injection, which is fairly new. Other subcutaneous administrations of PD-1, but this is a novel one. It's 300 milligrams Q4 weeks, and as you can see in the diagram, that's given along with BCG in this trial. It's pretty straightforward. So in the study, the patients were BCG naive. They had to have high-risk non-muscle invasive disease defined as T1, high-grade TA, or CIS, and they couldn't have had prior PD-1 inhibitors. And this was an interesting study. It was over 1,000 patients, randomized 1:1:1 to get either sasanlimab, BCG induction, and maintenance, sasanlimab with only BCG induction, or the control arm of BCG induction and maintenance. As you can see here, what's really important is that in this study, both the BCG in arms A and in arm C were given for 2 years, and the sasanlimab was given for just about 2 years as well, and that differs between each trial. Primary endpoint of this study was event-free survival, looking between arm A and arm C, and you can see the other secondary endpoints, including overall survival, listed here. In terms of the baseline demographics, the groups were pretty well balanced. Most patients had T1 disease. There was a smaller percent who had TA or CIS. Most patients had high-grade disease, and most patients had single tumors as opposed to multiple, although there was a fair mix there in the study. And now when we look at the primary endpoint, event-free survival, this was a positive study. You can see the hazard ratio was 0.68, the p-value was very significant, and the delta, looking at the 24-month or 36-month time points, was about 6 to 8% of patients who didn't have relapse because they got the PD-1. This effect applied whether the patients had T1 at baseline or CIS at baseline. When we looked at the overall survival, however, and this is with only about 40 months of follow-up, we don't see a difference in overall survival. We're calling this as a secondary endpoint. Toxicity was basically what you would expect for adding a PD-1 inhibitor. I don't think there were new signals based on what we know about most PD-1 therapies. There were serious treatment-related adverse events, though, in 17% of the patients who got PD-1, compared to only about 1.4% of patients who got BCG alone. So there is a risk of having more serious adverse events when you add a PD-1 inhibitor. So putting this together, what's the impact on practice? Well, I think that this may become an option for high-risk non-muscle invasive bladder cancer. It's not currently FDA approved, and we'll see how the agency rules on that and how the study evolves as it matures. Thinking about this in the big picture, is the side effects worth the benefit? We have a positive EFS, we have immature OS, but we have real toxicity. And I think we have to, as a community, have to come together and think through, is this worth it? Also, who's going to be giving this therapy? Is this going to be urologists who are probably less equipped to manage autoimmune toxicity, systemic autoimmune toxicity? Medical oncologists, will they be involved? I think that's an unanswered question. Then also, what will we do at recurrence? Will we have other therapies that could be effective? So moving on, I want to talk about the Potomac study. This looked at a very similar study that looked at durvalumab in combination with BCG. Here, the entry criteria was very similar. Actually, the study design was very similar, where we had 3 arms. The first arm was durvalumab plus BCG induction and maintenance. Here, the durva was given for 1 year. The BCG induction and maintenance, like the CREST study, was for 2 years. There was a sort of intermediate arm of BCG induction only. We won't really talk about that much because it wasn't the primary endpoint. And then we have a control arm of BCG induction and maintenance, again, for 2 years. And the endpoints were very similar. Baseline characteristics, also very well balanced here. There's not much to say. There was a higher proportion of CIS in this study. What's really interesting is the hazard ratio for Potomac was identical to the hazard ratio for CREST. Both of them were 0.68. And that gives us some confidence that this is probably a real effect. We have 2 phase 3 studies showing very similar effect to adding a PD-1 inhibitor. Interestingly, in this study, the CIS group didn't seem to clearly benefit from the addition of PD-1 inhibitors, but this study is actually an outlier. The CR rate for patients with CIS was 93% in both arms. That is much higher for BCG, for the patients in the third arm, than what you would expect from prior trials where the CR rate is about 60 or 70%. So the patients may have done exceptionally well in the control arm here. And I don't think that indicates that there's not a role for PD-1 in CIS-positive patients. When we look at overall survival, again, we don't see a benefit in the Potomac study either. This study has almost 5.5 years of follow-up. I think the study may need to mature further. Interestingly, the hazard ratio here was 0.8. The hazard ratio in the CREST study was above 1. It was 1.1. And so we need more time for this to mature. There's not much to say about the toxicity, very similar to what we saw in the CREST study. And as we put this together, what's the impact on practice? Well, I think just like CREST, this trial met its primary endpoint of EFS. I don't think there's less activity, as I said, in the CIS cohort. The control arm did exceptionally well. And actually, the CR rate in Potomac for CIS patients was higher than the CR rate in CREST. So I think we have to think through that. Overall survival, again, immature, and the toxicity is as expected, and it's real. The optimal duration of PD-1 therapy, I don't think is well defined. Is it 1 year or is it 2 years? I think future studies may answer that. But I do think we may need to see an OS benefit before this becomes widely available. The last study I want to talk about is the ALBIN study. This was a study of atezolizumab in basically the same patient population of non-muscle-invasive bladder cancer. This was only a 2-arm study, and in this study, patients got BCG plus atezolizumab or BCG alone. What I really want to call your attention to is the duration of BCG in the ALBIN study. They only got 1 year of BCG instead of 2 to 3 years, which is more commonly done here in the US. The endpoints were very similar in this trial as well. The atezolizumab was also given for 1 year. When we look at the primary endpoint, we actually did not see a benefit in the ALBIN study. You can see the hazard ratio 0.98. The curves are essentially overlapping, and probably no surprise, the overall survival curves are overlapping as well. Toxicity, again, was real. There were serious treatment-related adverse events in the atezolizumab arm that were at higher frequency than the BCG arm. So putting this together, I'd say this is a disappointing study. It didn't meet its primary or some of its secondary endpoints. Why? I think we're going to talk about this a little bit. I'm sure everyone has ideas. Shorter duration of BCG, perhaps. It was a smaller study. It was about half the size of CREST and Potomac. And also, this follows on disappointing results for atezolizumab in the BCG unresponsive patients, which was a study of SWOG 1605, where we saw a lower CR rate with atezolizumab. So maybe atezolizumab is not as good, although I think that's a matter of debate. This is just a summary, which you can reference later on if you download the slides. Just to finish off, we have a lot of other agents, and we're going to talk about them tonight, for non-muscle invasive bladder cancer. These include chemotherapy, intravesical TAR-200, an intravesical device that elutes chemotherapy, viral therapy like nadofaragene firadenovec, NAI, which is an IL-15 superagonist, and other therapies that are in development. So the space has become surprisingly crowded very recently, and there's a lot of ongoing trials. Again, I show this for your reference, not to read through it right now, but we really have a plethora of studies. It's great to see, but a lot of unanswered questions. And so with that, I'm going to stop, and we're going to transition to Dr. Love and Dr. Plimick and hear a little bit of their conversation. So thank you.
Good evening, everyone. Dr. Plimick and Professor Powles met with me separately to present a series of mini case discussions for your consideration, beginning with Dr. Plimick.
72-year-old man, active lifestyle, healthy, some hyperlipidemia, exercised regularly, had non-muscle invasive bladder cancer diagnosed several years prior. He had been through induction BCG and maintenance, and subsequent to that, gemcitabine docetaxel and also nadofaragene. His pathology at presentation was high-risk T1 non-muscle invasive bladder cancer, and after each of these treatments, he had maybe 1 or 2 TURBTs that looked clear, only to have a recurrence of, again, high-grade non-muscle invasive bladder cancer afterwards. He was referred to my clinic by one of my urology colleagues to consider pembrolizumab as treatment for his non-muscle invasive bladder cancer after these 3 lines of therapy. My patient asked a lot of questions. His main goal was to avoid cystectomy. He really valued his sexual function, and that can obviously, with cystoprostatectomy, take a hit with that intervention. But he did not want to do the pembrolizumab, mostly out of the concern for side effects, but also, I think, because it wouldn't give him high chances of a durable response. This particular patient that I'm presenting, I saw a year and a half ago, and that was before the TAR-200 device was available. Obviously, there are a lot of strengths to that treatment. I think here we like it. It's off the shelf. It's easy to place. And it's intravesical. It's not systemic, so we avoid those toxicities. It wasn't an option for this patient just because it wasn't available. But I'm curious now that it is, how do you layer the TAR-200 into your treatment recommendations for patients with non-muscle invasive bladder cancer?
Great. So just to summarize, as a patient of Dr. Plimick's who had non-muscle invasive bladder cancer, has had BCG, has had nadofaragene firadenovec, as well as gemcitabine and docetaxel. So had a lot of therapy in the bladder. And the question is, if they're fearful of a PD-1 inhibitor, we do have data from Keynote 057 suggesting that pembrolizumab has value in BCG-resistant disease. But this patient doesn't really want PD-1 and has talked about TAR-200. I wondered, Dr. Necchi, how would you counsel this patient? What would you tell them about TAR-200?
Yeah, great point. So it's one of the most difficult to treat cases that we may encounter in our practice. So, first of all, I would point to the fact that radical cystectomy is the most effective standard of care, and is the only standard of care in most of the geographical areas, like European Union and most of the extra US countries. So we have to counsel very, very carefully the patient and inform the patient to the benefits, the potential benefits in terms of possibility to be cured related to cystectomy. Second, there is a global message that is arising from the multiple trials that have been conducted and that I will summarize later on today, that is pointing to the efficacy of intravesical therapies in this patient population rather than systemic therapy. So with regards to the activity reported to as CR rates and preliminary long-term duration of CR rates, there is clearly a trend that clearly favors intravesical therapies with TAR-200, cretostimogene, or other newer intravesical therapies that are going from clinical trials to the real world, as compared to systemic therapy, also with the advantage of potentially limiting the side effects with local symptoms of irritation and nothing more, as compared to the potentially deadly events that may occur with the use of systemic immune therapy, also with the best tolerated drug that we can use today. So these are the 2 points. First, we have to assure that the patients really want to avoid, and the reason why the patient want to avoid cystectomy, which is the standard of care, and then pointing to the intravesical therapies as the primary choice in these particular patients when it comes to try the further therapies that they may be approved or not approved in your particular country.
Great, thank you for that. Dr. Gupta, we have a lot of these therapies now available, right? There's viral therapy, there's chemotherapy, there's sort of other novel targets. So, we don't have head-to-head data. But how would you counsel a patient? What would you say to them if you had, for example, many of these therapies available? How do you counsel them? How do you think about that?
Yeah, so as you know, this is primarily a urologic disease, but we are seeing more and more of these patients who come and talk to us. So I think none of these trials, we can't compare trial to trial, and there's no sequencing data that we have. So I think it all depends on how much can a particular patient's bladder take, and I've asked this question to my urology colleagues, and I think it all depends on how friable it is, and can they keep giving more intravesical therapies or rather proceed with cystectomy, like Dr. Necchi said, which is the standard. But I think it's great to have these options so that patients can get exposed to these agents in sequence, but we don't know what that right sequence is yet.
Right. It's really a balance of preserving the bladder, keeping that intact, because a cystectomy is a morbid procedure. As beneficial as it is, it can also be very challenging from so many levels. Dr. Galsky, what do you think about the role of PD-1? This patient's fearful of the side effects of PD-1. Are there things that the patient might not be kind of thinking about in terms of disease progression or risks for side effects from more localized therapy? How do you talk to a patient about that?
So I think it's important to recognize that none of the treatments that are being discussed have been studied in a patient like this who's received multiple lines of prior treatment intravesically and has high-grade T1 disease. I'm really worried about this patient. I think that declining cystectomy is sometimes based on how the procedure is framed and the balance of risk versus benefit and what the risk of disease is in that patient. So I would reinforce the risk for metastatic recurrence in a patient like this. I think systemic pembrolizumab, because of that, is not a horrible idea, but again, it hasn't been studied in someone who's received multiple lines of intravesical therapy. TAR-200 in a patient who's received prior intravesical gemcitabine, I don't know about the effectiveness of that. There certainly could be a PK advantage to the intravesical delivery system, but at the end of the day, it's the same drug. I would say that if this patient declined everything else, I might be leaning toward BCG and NII in this patient. We know that BCG retreatment has a role, even in the absence of NAI. And so from a non-cross-resistant regimen standpoint, in a patient who is really declining cystectomy, that would probably be the regimen that I would favor in the absence of data.
Okay, thank you. And so we talked about TAR-200, and I know, Dr. Necchi, you're going to talk much more about this, and actually tomorrow you're going to be presenting prospective data about TAR-200. So for folks who maybe aren't that familiar with it, how do you describe this? You put many patients on trial. What do you tell them this is? Is this just chemotherapy, or is it something more?
Yeah, the drug is not new. It's new the way we deliver the drug into the bladder. TAR-200 is now called gemcitabine intravesical system. You will now see that it is referred to as GEM-IDRS, gemcitabine intravesical system. Is a way of delivering gemcitabine into the bladder through a silicone tube that release in a continuous way the gemcitabine drug into the bladder. It is put with a catheter in an outpatient procedure, so very, very easy. The patient come in the morning to the clinic, receive the deposition of the drug, and then goes home without any major side effects for the majority of the cases. So it's a very, very simple procedure, and the removal of the drug usually occurs every 3 weeks. So it could be pursued in a long-term fashion. So it's a very easy procedure, but also requires, in any case, a procedure, a surgical, an endoscopic procedure, a catheterization, an hospital procedure to be put. So it's not something that could be done at home, at least for the moment. But anyway, the safety profile and the way it is put into then removed and substituted into the bladder is very simple. And what is making the key actually for the drug is the continuous exposure of the tumor to the drug as compared to the peak of the concentration of the drug that is usually very, very short-living when putting the drug as an instillation into the bladder.
Yeah, so it's a very long-lasting, durable benefit or exposure to drug as opposed to just a one-time. Let me ask you, Dr. Necchi, what would you ultimately recommend? Dr. Plimick didn't have access to TAR-200. It's now FDA approved for CIS patients with CIS refractory to BCG. Would you recommend TAR-200 in this case, or would you go with something else?
Well, with all the limitations that Matt has raised. Limitation of the data in this particular case, in this particular situation, based on the fact that the patient still is against radical cystectomy, I would use TAR-200 as an option for the patient.
All right. Great to hear. Okay. And now we're going to hear from Dr. Puls.
Professor Pauls has for your consideration a very fit man in his late 70s with CIS.
It's a new presentation of non-muscle-invasive bladder cancer. The classic treatment would be BCG induction and maintenance. And the question is whether now, because of these two positive trials, CREST and POTOMAC, and of course the one negative trial with atezolizumab, the ALBAN trial, whether this is the right treatment for this individual. Should it be BCG alone, induction and maintenance, or should we add in an immune checkpoint inhibitor? And I had a chat with this guy. He was prepared to buy drugs himself and go because they're not currently licensed. He said to me, look, Tom, what would you do with unlimited resource and in this setting? And you know what, Neil, the discussion's really complicated. I said to him, look, I probably wouldn't take the risk. I would do BCG induction and maintenance. I'd keep a close eye on things and we'll see where we go. And if the cancer was to come back, we can then have a discussion about further treatment options. And then he said to me, well, hold on a second. I read in one of the papers that CIS patients do even better with this. And I came back to him and said, well, there is in one of the studies, but in the other study, the opposite is true. And so I just said to him, if you were older and you were unable to have a cystectomy, or if you said to me, Tom, I'm not having a cystectomy under any circumstances, and I'll do anything to avoid that, that might be a slightly different discussion. But at the moment, I would stay on the current pathway.
Okay, so just to review, this is a patient with frontline NMIBC with CIS who has unlimited resources and can get any drug they want. And so what they want to know is, should he be adding a PD-1 inhibitor to his frontline BCG, assuming it's available? And so the question is that the right thing to do? And I guess, Dr. Gupta, how would you counsel the patient if they had this option? And I've sort of given my opinion in my talk, but what do you think?
I think, if we had access to this drug, we have to, in due diligence, discuss the full data, right? 2 years of immunotherapy, it did have substantial toxicity in this study. But like Dr. Powell said, it did show in this particular study that patients with CIS derive more benefit. And if we look at other studies, it didn't show that. So I think we also know that the control arm did very well in this study. BCG was very good. So I think if we had this available and patient was willing to take the risk of the long-term toxicities with 2 years of checkpoint inhibitor in this very early stage, then that's the informed decision we have to make with the patient.
And Dr. Galsky, when we look at the data, the delta between the two arms for both trials for EFS was between about 6 or 8%. So we're giving a lot of drug to people for a modest benefit, to prevent 8% of patients from having a relapse. Is that compelling in your view? And we don't have overall survival data yet. We may never have overall survival data. How do you interpret that?
So I think it depends on what the events are. And event-free survival is a composite endpoint, and so those events mean different things in different contexts. I would not expect to see a survival benefit in this clinical disease state. That is not an immediate threat to these patients, but what is an immediate threat is progression that would require more morbid treatments and more life-altering treatments, and preventing that to many patients is worth that trade-off. So I think this is a shared decision. Right now, we really don't have the option. This is not an FDA-approved treatment. None of these are for this particular indication. But I think if they were, then for a patient who's informed and says, I want to do everything to make sure that this is the only treatment I need for this disease ever, I think it's a reasonable trade-off.
Yeah. And then in terms of the side effects, I'll just sort of add, we saw real toxicity with this. And so I think if these drugs become approved, just like using PD-1 inhibitors anywhere else in the field of oncology, we really have to counsel these patients well. These are patients who are having their very first interaction with oncology, with having cancer. They may not really understand the gravity of some of these autoimmune side effects. So that can be pretty significant. I guess, Dr. Necchi, do you think there's an ideal candidate to get PD-L1? Do we have a biomarker that can say, this patient should get PD-L1 with BCG and this patient probably won't benefit? Because we saw, as I mentioned, discordant results in the CIS group, although I think that might be explainable. But how do you interpret that?
Well, not at least at the moment, based on the biology of the disease that may orient us towards a certain decision. In this case, it's fully a patient-driven decision, right? Because we stated that the patient can access to any kind of therapies. So it's a patient decision. One thing that I would put as a safety barrier prior to decide, just as a way of counseling in full the patient that they have to decide. There is also the point of the attrition rate and the way of preventing the patient to receive any kind of systemic therapy, effective systemic therapy later on, in case they develop a relapsing disease or progressing disease. So one thing they should be put into the table when they're in the discussion is the fact that the magnitude of effect that they demonstrated with addition of an immune checkpoint inhibitor towards BCG versus BCG should be counterbalanced with the magnitude of loss of effect they could be affected with in case they they experience a disease progression and they could not access, or at that time would be prevented to receive, for example, EV-Pembro later on, or immune checkpoint inhibitor combination therapy later on. So there is a new point, a new argument to make with regards to the sequencing of therapies that starts exactly from this situation, from the BCG naive, a very first diagnosis of bladder cancer.
Right, so it's not only planning for today, it's planning for tomorrow. And if you use your PD-1 agent early in the disease course, what are you going to give later? I don't think we have a lot of data, but I'd love to hear from our panel here. Is there any data that suggests that you can give a PD-1, patient gets resistant, and then give a PD-1 later? My view has always been that we shouldn't be waiting to give PD-1 inhibitors to patients with bladder cancer. The avelumab Javelin Bladder 100 study of avelumab showed us that earlier avelumab associated with significant survival benefit. My view has always been that getting the PD-1 into the veins of the patient is what really matters, getting that in early. And then we saw that in 302, where you see earlier PD-1 was beneficial. EV302, the frontline study of EV Pembro. But is that true now in this early phase, in this non-muscle invasive phase? And Dr. Galsky, I guess, how do you think that that's a valid argument? I've heard sort of controversy about that.
Yeah, I mean, I don't know that I would frame it in terms of earlier use is always better, but I would frame it that in any clinical disease state, I never really buy into the argument of saving something for later. Like our goal with any of our treatments is to try and get rid of the disease, short of metastatic disease, where of course that's more challenging. But in all of these disease states, this is curative intent treatment. And so to withhold something for later, why would you not give your best shot up front, right?
Right, but of course the counter argument is against toxicity and other issues. As we're going to, go ahead.
And I think that's a totally legitimate argument. If that's the argument for saving it, that's reasonable. If the argument is that I want to use it later, that doesn't make sense to me. Because if the biology is such that you give it now and the disease comes back, then that biology would not have benefited from getting it later.
Later, right. So perhaps there's no magic to giving it later with EV or with another agent. It's like put your best foot forward, but balance that against the toxicity. So I guess, do you think that there is, Dr. Necchi, do you think that there is some value to the PD-1 plus BCG? That's a double immunotherapy. We have TAR-200 plus citrilimab, which is giving chemotherapy with immune therapy. Do you think that there's some synergy or some connection here that makes this a more valuable therapy than giving it with chemotherapy or other agents?
It's difficult to say at the moment because based on the trial data that we have today, we cannot dissect clearly the contribution of systemic therapy over intravesical therapy with regards to the numbers that we have, EFS data, clinical complete response rates, and so. We should definitely wait for the ongoing trials with combining TAR-200 and systemic therapy. We will show you which kind of design are being completed or ongoing. But at the moment, it's very difficult. And based on the data, for example, that we show you in the non-responsive setting with TAR-200 and something else, as compared to TAR-200 monotherapy, it's difficult to position systemic checkpoint inhibition in this patient population.
Right. So maybe there is a difference depending on which agent it's being partnered with. We saw that in the metastatic setting. Actually, Dr. Galsky had a great paper that looked at the difference between cisplatin and carboplatin, the immunologic effects. We can maybe talk about that in a little bit. I want to move on to Dr. Gupta's talk, who's going to talk about muscle-invasive bladder cancer. So Dr. Gupta, take it away.
Thank you, Dr. Friedlander. So we'll talk about the evolving management of muscle-invasive bladder cancer, which is really rapidly evolving, and we'll see some new practice-changing data at this meeting. So we know there have been 3 adjuvant immunotherapy trials in high-risk muscle-invasive urothelial cancer, and these patients were defined as if they received neoadjuvant cisplatin-based chemotherapy, then YPT2 or higher, and if they were not cisplatin eligible, then PT3 or higher. So the first trial was IMvigor010, which randomized these patients to atezolizumab versus observation. Even though this study was negative, it has really advanced our understanding of circulating tumor DNA based on the subsequent study of IMvigor011, which I think Dr. Galsky will talk about. Then the second study led by Dr. Galsky was CheckMate 274, which was randomizing these high-risk patients to nivolumab versus placebo. Primary endpoint was disease-free survival, which was met. Overall survival is trending in the right direction, but not significant yet. And the third study to read out was Ambassador trial of pembrolizumab versus observation. There was disease-free survival improvement, but no overall survival improvement. I want to add here that these studies did include upper tract urothelial cancer patients as well, but they were only a minority of the population. So this is the 5-year follow-up that we saw from ESMO presented by Dr. Galsky. The CheckMate 274 disease-free survival benefit was maintained even at 5 years, which is really reassuring. And it was more pronounced in patients whose tumors were PD-L1 positive. And just for the audience, in Europe, the approval is based only for patients whose tumors are PD-L1 positive. But in the US, it's for all comers. And in this, we also saw when you break it down by MIBC, not including the upper tract patients, the benefit was even more pronounced. And we see that the 5-year overall survival trend is heading in the right direction with adjuvant nivolumab. Now, there's been a wealth of trials with immunotherapy in the perioperative space, and some of these trials have read out. In the cisplatin-eligible space, the first immunotherapy-based trial to read out was the Niagara trial, which used perioperative durvalumab and Gemcis versus Gemcis. And I want to highlight here that this was a unique study because the eligibility for cisplatin creatinine clearance was threshold of 40 mils per minute, not 60. And that's why there were several cisplatin ineligible patients who could safely get cisplatin in this as well. The other trial in the cisplatin ineligible space that we saw at ESMO last year was the Keynote 905, which tested pembrolizumab and EV versus upfront radical cystectomy because these patients undergo upfront cystectomy. And this was a trial that met primary endpoint of event-free survival as well as overall survival and has been approved in this setting in the United States. And the trial Keynote B15 or EV304, which is looking at Pembro EV versus Gemcis in the perioperative setting, will be presented at this meeting by Dr. Galsky. I want to highlight here that none of these trials included adjuvant immunotherapy in the control arm, even though nivolumab was approved during the conduct of some of these studies. So looking at the Niagara study, this did include patients with node-positive disease. It was a pretty forward-looking trial, included variant histologies. And like I said, the creatinine clearance was 40. In the real world, we are really comfortable treating patients with cisplatin with late 40s or 50s, but this was 40, and they received split-dose Gemcis. Primary endpoints were event-free survival and pathologic complete responses. And this study met the event-free survival endpoint. We look here at the pathologic complete response, and we can see that even the comparator arm did not perform as well as we would hope Gemcis to, and this was not statistically important, the pathologic complete responses with the combination. Moving on to EV-Pembro, we've seen in the metastatic setting that it has really revolutionized the frontline treatment of metastatic urothelial cancer, and it's the preferred standard of care globally. And I don't want to go into the details of the data, but no matter how you slice and dice the data, this regimen is the go-to choice, regardless of cisplatin eligibility, regardless of PD-L1 expression, regardless of liver metastases, visceral metastases, and overall response rates were significantly better. And even at 2 years, patients who achieve a complete response have really a very high probability of being alive, as we showed last year. And this has obviously set off a domino effect in muscle-invasive bladder cancer, where it has since moved. And the Keynote 905 study was at ESMO last year. Of note, this did not include any upper tract patients. This was a perioperative study, included T2 to T4, N0, M0, or node-positive patients, although they were a minority. Patients needed to have more than 50% or 50% or higher urothelial histology, and cisplatin eligibility was defined by the Galsky criteria, where the creatinine clearance was 60 mils per minute or cisplatin declining. And it enrolled even patients with ECOG performance status 2. So patients got 3 cycles of neoadjuvant EV pembro and then underwent cystectomy and node dissection, and they were randomized to observation versus EV pembro for an additional 6 cycles. And notably in this patient population, the standard of care is only TURBT followed by cystectomy. So they didn't get anything neoadjuvant. And as we look here, there were more older and frail patients enrolled on this trial, looking at patient population 75 years or higher. That is really more than what we've seen in any other similar trials. Around 12 to 14% patients had ECOG performance status 2. And you can see these patients had more aggressive disease, with T3, T4 being the majority. And these curves speak for themselves, so you can really appreciate the magnitude of benefit that EV pembro has added in this patient population, with event-free survival not reached versus 15.7 months. And this is the median overall survival also not reached versus 41 months. And no matter how we look at the subgroups, all the patients benefited from EV pembro. And the good news with this trial was that patients were able to undergo surgery successfully after EV pembro. This was the key secondary endpoint where we see that the pathologic complete response rates with EV pembro were 57%. And I think this is really unprecedented across all neoadjuvant trials that we've seen, whether it's dose-dense MVAC or GemCis or GemCis durvalumab. So this is the highest pathologic CR rates we've ever seen with any regimen. And of course, with the control group, we don't expect anything different from just TURBT. So 67% of patients were able to get adjuvant therapy in this study, and we don't know the exact reasons why 1/3 of them did not get adjuvant therapy. It's possible that they were beginning to get some toxicities and then undergo this huge surgical procedure and just could not start the regimen. But overall, this is you can see that the grade 3 or higher toxicities were seen in majority of patients. That is 71% patients. And in 48% patients, it led to discontinuation of any drug. And there were some deaths, although not directly related to the study at that. So I think this is something which comes out of this study, that the data is great, but we really need to be mindful of the toxicities and how to manage them and make that decision in the adjuvant setting. And we've seen this press release so far that in the B15 study, EV pembro improved event-free survival and overall survival compared to GemCis, and really looking forward to the session tomorrow morning. So in conclusion, immunotherapy is now a backbone of perioperative treatment in MIBC, and EV pembro will revolutionize treatment further, truly replacing the platinum. While GemCis nivolumab was a big step forward, it still involved a platinum backbone, which no longer will be the case in future. But we still need to personalize adjuvant therapy duration in patients with pathologic complete response, because if we had a patient with MIBC who had a path CR to any therapy, we wouldn't really be talking about any adjuvant therapy, either nivolumab or pembrolizumab. So do we really need to keep giving EV pembro even post-op? I think that's a big question we need to address, because there are added toxicities with these drugs. And then there's a question of exploring bladder preservation treatment strategies with such effective regimens and making it a reality for our patients if they achieve a clinical complete response.
Great, thanks so much. So now we're going to go to a video segment with Dr. Plemick.
Adjuvant therapy of muscle-invasive urothelial bladder cancer took a major step forward at the October ESMO meeting when Professor Pauwels presented the IMvigor011 trial, and Dr. Plemick presented a patient she evaluated last year before the data were available.
She was 68 years old, T3N0 upper tract urothelial carcinoma resected. And based on the pathology, she was referred to a local medical oncologist who recommended adjuvant nivolumab. She sought a second opinion. So I'm curious, how would you have thought through this case? What would you have advised her?
So what actually did you discuss with her?
So we discussed the adjuvant nivolumab data with Checkmate 274. We did discuss the subgroup of upper tract urothelial carcinoma, which did not appear to benefit, as did the whole group as a whole. At the end of that conversation, she was hesitant to proceed, and so we discussed further using ctDNA to help make a decision. We ordered the Signatera test. Her CAT scan was clear, and her ctDNA was negative. What would you have done in this situation? She decided to be observed without adjuvant treatment. We've had at least one follow-up scan and repeat ctDNA. Those are both negative as well. So far, so good. For this particular patient, I ordered ctDNA to try to inform our decision. Is that something you do in routine practice? I elected to use the Signatera assay, which is a tumor-informed ctDNA test. What test do you all use in your clinics in this situation?
Great. So this is a case of a 68-year-old woman with upper tract urothelial cancer. We've mostly been talking about muscle-invasive bladder cancer, who's now had the tumor removed and is considered high risk for relapse, but technically is disease-free. And so I know we didn't focus so much on the adjuvant nivolumab data, the Checkmate 274 data, but Dr. Gupta, how would you advise that patient? And do you agree with Dr. Plimick that there's not great data for the upper tract patients to get adjuvant nivolumab?
Yeah, I mean, adjuvant nivolumab is approved for both MIBC and upper tract disease, but if we do look at the subgroup analysis, the upper tract patients did not benefit, but that's also true for any adjuvant IO trial, both the IMvigor010 as well as the Ambassador trial. But I think we do have a valid option for this patient, adjuvant GemCis or GemCarbo, based on the POUT trial, and that's the only level 1 evidence to date in adjuvant upper tract. So I'm curious if Dr. Plimick discussed that or not, but I think that is something I would discuss with the patient.
So you might lean towards discussing adjuvant chemo, which feels a little retro these days, as opposed to an adjuvant IO. Now, Dr. Galsky, you had a major role in this trial. Do you want to have anything to add to that assessment, or would you have treated the patient differently, just without the cell-free DNA, just based on pathologic data?
Yeah, so I think we have to be careful about making major conclusions from hypothesis-generating underpowered subgroup analyses. If you look at the subgroup analysis for upper tract disease for the DFS endpoint in Checkmate 274, the effect size did seem to be less, but if you look at the overall survival subgroup analysis, that wasn't true. And so it just goes to show you, if you look at multiple subgroups, you can be misled. So I don't view that data as definitive for not recommending adjuvant immune checkpoint blockade for patients with upper tract.
So you think that would still be an option for this patient?
Absolutely.
And how do you think between, we have the POUT data, which looked at adjuvant platinum-based chemotherapy that was beneficial, and you have Checkmate 274 looking at adjuvant Nivo. How do you counsel a patient? And we're in an era where actually GemCis Nivo is considered a standard perioperative regimen, technically neoadjuvant. Is there a role for giving platinum plus a PD-1 to someone if you think they're high risk, especially for upper tract, or do we not have enough data to kind of go there?
So we don't have data. The neoadjuvant data for platinum-based chemotherapy plus immune checkpoint blockade in upper tract disease, the path CR rate is fairly low, and so that does bring some pause to that general approach, but we don't have data in the adjuvant setting.
Okay. So now the patient got cell-free DNA, and they used the Signatera test, which is a bespoke assay. Tumor gets sequenced, probes are designed based on the identified mutations. Later on, they get blood drawn, and then the DNA, those specific mutations are looked for in the blood. And there's a lot of data that's been generated showing that this has a lot of prognostic importance. I'd love to ask maybe Dr. Necchi, I know in Italy you don't have as much access to this. Are you able to send an assay like Signatera, or is that harder for you in international?
Yeah, well, anytime I see discussing these opportunities, I remain frustrated by the fact that most of these opportunities are actually not available in most of the extra US countries. For example, just to make an example, Italy as an extra, is a European country. We don't have access to Signatera test, even as an out-of-pocket test. There is no way of accessing the test outside of clinical trials or outside of research protocols. There is no way to access adjuvant nivolumab today. It's not reimbursed. Actually, it's a very theoretical discussion, And I suspect that for this patient population in particular, adjuvant nivolumab will never be a reality in this population. On the other side, we do have chemotherapy. In the POUT study, as Shilpa has mentioned, it's clearly indicated that there could be an opportunity also to spare most of the renal toxicity by using carboplatin. But my general feeling, my experience is negative towards the use of chemotherapy adjuvantly in this patient population for multiple reasons. And the vast majority, if not all the patients with this particular situation, will start the follow-up phase and strict surveillance instead of doing anything.
Dr. Gupta, do you think there's a role for ctDNA in this patient? Because obviously, Dr. Plimick ordered it and saw it was negative and then felt a little more comfortable recommending surveillance. How would you approach it?
Yeah, I think, we are all ordering ctDNA because unlike Italy, we do have the luxury to order it here. Although I think it's important to keep ordering it serially. And at this point, we don't have that data from upper tract disease. But I think it's reassuring that it's negative. To be honest, we're all doing it. But I'm personally not changing treatment if just ctDNA becomes positive and the scans are still negative.
So you'll still follow a patient. So maybe it's an early marker of disease recurrence, but you're not yet comfortable to actually give someone therapy based just on a biomarker like ctDNA. Matt, do we have good data about upper tract ctDNA and recurrences? Do you think that this is there a future for upper tract disease here with ctDNA?
So in Vigor 10, which was the retrospective analysis of the adjuvant atezolizumab study, of course, that study did include patients with upper tract disease. And so there's upper tract data from that study. In Vigor 11, the prospective study, which I'll get into a little bit, didn't include patients with upper tract disease. So we have clinical validity data. We don't have clinical utility data.
And then in your practice, are you routinely getting ctDNA on a non-trial patient? If so, are you using the Signatera assay or a different one?
I'm routinely getting it. I'm routinely using Signatera just based on, again, both clinical validity and clinical utility data in urothelial cancer, where we have some data but not as expansive data for other assays at this time. And I would say a little bit flipped from some of the discussion. It's helpful to me in informing a decision if it's positive. If it's negative, it doesn't help me, and I'll go through the rationale as to why.
Okay, I think that'll be helpful. We'll look forward to that. So at the end of the day, Dr. Plimick sort of used it to give some reassurance. It sounds like you have a little more hesitancy about using that. Clearly, there's not a prospective validation of using it in that context. So, okay, I think we'll move on to the next discussion between Dr. Love and Dr. Pauls.
Professor Pauls evaluated a 77-year-old man who was status post-surgery for a clinically T3 muscle-invasive lesion.
He had a cystectomy, and he was shown to have that T3 N0 M0 cancer. It's a pure urothelial cancer. This individual turned out to be PD-L1 negative. We didn't have any ctDNA on him. And the question is, where are we with this patient right now? This is a patient from about 6 months ago, Neil. Would I have given this patient adjuvant nivolumab? I offered it to him because I think having some perioperative therapy is attractive. But in today's world, it would be EV Pembro. And then even if that EV Pembro data didn't exist, because of InVigor 11, I actually would rather do ctDNA analysis. And if they were positive, I would give them atezolizumab or nivolumab. And if they were negative, I would track their ctDNA. And if they became positive, I would give atezolizumab. So this is a field that's changed incredibly over the last 18 months. And it's a complete shift away from surgery and towards EV Pembro or circulating tumor DNA.
Okay, so there's actually a lot to unpack in this case. This is a 77-year-old man who has MIBC, poor renal function, so not a cisplatin candidate, who's PD-L1 negative. Now, PD-L1 is an interesting biomarker. In urothelial cancer, it's actually been quite controversial Because with the exception of perhaps Checkmate 274, which we'll discuss, it really hasn't had significant value as a biomarker to tell us who to give therapy to. That said, and Dr. Necchi, please back me up here, in Europe, the approval for adjuvant nivolumab is based on a PD-L1 assay, correct?
Yes, the label is for PD-L1 positive tumors, yes.
So in this patient who has PD-L1 negative MIBC, it sounds like it might be hard to even give this. Would you give it, though, if you had the option to do it in PD-L1 negative, sort of ignoring the difference between U.S., where it's approved regardless of PD-L1 status, and in Europe? Or do you really agree with the European determination that this should only be for PD-L1 positive?
Well, difficult to say, because it mostly depends on the patient commitment and the result for the decision where to do. What to do in this patient population is very, very highly dependent on the patient desire, on the patient willingness to and ability to follow surveillance, close surveillance, and how they perceive their risk in the time course post major surgery. So the decision should be very, very personalized. In patients who would like to get any kind of treatment to reduce as much as possible their risk to relapse, nivolumab adjuvant nivolumab is still an option, and the benefit in the PD-L1 positive patients, as we have seen within the latest update, is confirmed. So the magnitude of effect in PD-L1 positive patients is there. So the decision by the EMA to restrict the expenses to the PD-L1 positive patient is not something that is on the moon. Is actually a rational decision. But in this case, if he is strict, very willing, and very much committed to receive any kind of treatment, to play any card to reduce the risk of therapy, I would say yes. If he's skeptical about possible toxicity, or if he's totally free to accept the risk to relapse and being closely surveyed for the long run, I would be much more in favor of starting surveillance phase.
Okay, so maybe surveillance would be appropriate if the patient is going to have good follow-up, but perhaps if they really want to prevent recurrence, we might give adjuvant nivolumab there. So here's a provocative question. I'm going to ask Dr. Gupta. We have perioperative data, a sandwich approach of EV and Pembro neoadjuvantly followed by adjuvantly, approved, as you just discussed, for patients who are cisplatin ineligible, and that's available today in the United States. So you say you have a patient who saw the urologist, went straight to surgery. Would you offer them just the adjuvant portion of EVP? We don't have a study that specifically looks at that. How do you think about that?
I would not offer them EVP. But, if it's a patient who's cisplatin ineligible, very high risk, then it's a matter of time that if they recur, then EVP is the option. But I would not just offer EVP.
Yeah. Can you say more about why? Is it risk of toxicity, or is it just because we don't have the data, or is it kind of a mix of all of that?
I think, just based on lack of data as a purely adjuvant regimen.
Okay. Dr. Galsky, you're going to talk a lot about cell-free DNA in just a little bit. The IMvigor011 study was a major study presented just in October at ESMO, and this used cell-free DNA to help guide the decision to give adjuvant therapy. I'll also point out that you're leading the modern study through the Alliance Cooperative Group, which is also a cell-free DNA or circulating tumor DNA guided study. So do you think that there's value in this patient? This is, again, NMIBC, trying to decide on adjuvant therapy. Do you think there's a role for cell-free DNA here?
I think there's a role if it's detectable, as mentioned before. If it's undetectable, I think that we have to be much more cautious. And again, I'll go through the data and point out why. But the study was designed to address a ctDNA positive question, not a negative question. Even though there's data, that's not the way that the study was designed.
Okay. So it sounds like more to come there. So, you've already said that you think using ctDNA positivity is really where we need to focus, not on ctDNA negativity. What's the value of the longitudinal monitoring, right? In some studies, we've only seen, for example, one post-operative assessment of ctDNA. In other studies like IMvigor011, they followed patients for a year. Can you talk to that, explain that a little better?
Yes. So in a patient who has undetectable ctDNA, and I'll go through the study design from IMvigor11 in the data, but in patients with undetectable ctDNA, they had serial monitoring on IMvigor11 every 6 weeks initially for a year. And in patients who had detectable ctDNA, they could initiate immune checkpoint blockade at that time. So in a patient who the decision has been made to monitor, then absolutely, I think there's a role. This is a new clinical disease entity, molecular recurrence. Now we have prospective data that one can intervene on that clinical disease state in a meaningful way and impact outcomes. So yeah, now I think it should be done.
And I get this question a lot, and partly because the Natera company will actually contact the patient and say, how frequently do you want to get this test done? Sometimes the patient turn to me and they say, how frequently should we do it? Should we do it once a month, 6 weeks, every 3 months? What's your approach?
So we've been doing it every 3 months for the first year historically, and then the IMvigor11 data came out and it was every 6 weeks, and I think that's really where we have the data suggesting a benefit for intervention. It becomes a little bit more cumbersome to do it every 6 weeks when we're not seeing the patient, although there are home draws and things like that, so it can be done. And I think if you really follow the data, then following that schedule is probably the right thing to do.
Right. Do you think, just let's hypothesize for a second, do you think there's a difference, Dr. Gupta, between 6 weeks and 3 months of monitoring?
I think to Matt's point, and the 6 week is more attractive to me because then you can move up the scans. I've had a couple of patients who got their report before I did, and they sent me in basket that my ctDNA is positive. So I moved up the scan, and I did find something. So I think doing it before like many weeks before you are supposed to do a scan kind of makes sense for the whole reason why we want to do it.
Right. For many of you who don't treat a lot of bladder cancer, I find there's a lot of parallels with PSA and prostate cancer, which is a biochemical test that strongly predicts recurrence. You can see it go up. I think it's harder to know what to do with that data as a predictive marker to tell us what therapy to give. And I think perhaps Dr. Galsky will give us a little more insight to that in just a few minutes. So we'll move on to Module 3, and this is going to be Dr. Necchi talking about the role of current and future roles of novel intravesical therapy in NMIBC.
Thank you, Terence. Let's go back to the earlier stage, to the non-muscle-invasive disease stage, to which we will primarily focus when dealing with the newer intravesical therapies in the development and in the real world also. We do have unmet needs across the clinical stages for non-muscle-invasive and muscle-invasive disease, so organ-confined, non-metastatic tumor. Most importantly, we have issues related in non-muscle-invasive disease to the BCG, the BCG failure in particular, to which we will concentrate our focus when dealing with newer therapies. We are lucky because we do have shared definitions across the disease states in non-muscle invasive disease. So we do have a standard of care, standard definition of high-risk non-muscle invasive disease, and we do have shared definition of adequate BCG exposure and BCG unresponsiveness or refractoriness to the treatment. So we do have a framework to which we could discuss, we could put the data coming from clinical trials. This is a summary, a very high-level summary of what is going on in terms of newer therapies in patients with NMIBC, with unresponsive BCG, which is unresponsive to BCG. You see multiple options. We will navigate through most of these options, in particular with the focus on the intravesical therapies. But we do see here a lot of systemic therapies also that have been tested together with or alone as monotherapies in this patient population. So TAR-200, now called gemcitabine intravesical system, has been tested across the clinical stages in non-muscle-invasive and muscle-invasive disease. We will navigate through the currently available data from clinical trials and the trial in progress that could reshape a little bit the way we use this compound in patients with bladder cancer. Let's start first from the Sunrise-1 study. Sunrise-1 is the first study providing data on the TAR-200 in BCG unresponsive population. In particular, cohort 2 of the study, which is referred to as monotherapy with TAR-200 in patients with the BCG unresponsive CIS with or without papillary component. And the data that we do have with the primary endpoint of clinical complete response rate and the further data of durability of response have been already published. And the data that we have in publication in JCO and on the latest update show that the CR rate was quite compelling as compared to the data of CR rates that we have reported with systemic therapy. So more than 80% of the patients achieved a clinical CR to this treatment. And you see on the right-hand side here the proportion of patients who get maintain complete response over time is also very much compelling. And we do have the curve of the duration, the durability of CR. Here, response referred to CR, durability of CR, not just responses, with the 52% projection at 2 years, which is quite compelling in this patient population and position this drug as being one of the FDA-approved option in the United States. And let's see what will happen outside of the United States with regards to the accessibility of this compound. The safety profile is another important point that Terence has mentioned before with regards to patients in a curative setting with a non-metastatic disease that potentially may be impacted by the few side effects that may occur even with the use of systemic immune therapy as monotherapy. The vast majority of the side effects here are side effects related to the local symptoms of irritation and are pretty well manageable quite easily in an outpatient way. Unfortunately, on the other side, we do not have any biomarker at the moment that may orient us towards the decision-making, towards the treatment choice, favoring TAR-200, because the data in Sunrise-1 pointing to the PD-L1 expression on the left-hand side or TMB or MRD status on the right-hand side were not actually indicating that there was an association between biomarkers and the benefit and the clinical CR. Another cohort of the study was cohort 4, which is a pretty unique cohort of papillary-only disease, T1 and Ta disease without CIS component, TAR-200 monotherapy in this patient population, for which we do not have much data from clinical trials. Disease-free survival is theoretically the primary endpoint for this patient population, and event-free survival here and disease-free survival shown here is also quite compelling as compared to the historical data, in particular pointing to the results with pembrolizumab monotherapy that resulted in quite lower rate of maintained disease-free status. An ongoing study is Sunrise-3. Sunrise-3 study is for BCG-naive patients with non-muscle-invasive disease, high-grade TA, NET1, or CIS, so including CIS, being randomized to receive TAR-200 and cetuximab, checkpoint inhibition, TAR-200, or BCG. This could be a transformative trial if positive, because this would allow us to go beyond the limitations of BCG, like GEM-Cs for MIBC or GEM-Cs for first-line chemotherapy in metastatic setting. This could be really a way to overcome one of the pillars of the treatment of patients with bladder cancer. Another ongoing study is Sunrise-5, which is targeting the very particular population of papillary tumor without CIS, BCG exposed, being randomized to receive TAR-200 monotherapy as compared to intravesical chemotherapy. This is another unmet need for another difficult to treat patient population with papillary-only tumor with prior BCG exposure. Another intravesical therapy that has provided their results is cretostimogene, is an oncolytic intravesical therapy that has provided results quite similar to those with TAR-200 with 75-76% of CR at any time and maintained CR in 74% of the patients with a similar safety profile. It was based on the US-only trial, so the validation of the real world of this data in a worldwide perspective is still unknown. It is still an ongoing process. FGF receptor mutations are pretty well targetable, as you well know, in bladder cancer, and are pretty well enriched in patients with NMIBC. So TOR2 trial was the first trial to test erdafitinib, so a systemic oral pan-FGF receptor inhibitor in patients with non-muscle-invasive disease. Multiple cohorts that provided data, in particular patients with CIS unresponsive, BCG unresponsive, or other data in papillary cohort or in marker lesion cohorts. And the trial was positive, actually, for DFS, at least in the cohort 1 of the patient population. But actually, based on multiple reasons, primarily due to the safety issues encountered with erdafitinib monotherapy, the trial did not result in a new standard of care available worldwide in this patient population. It's a different story. TAR-210 is a different story because TAR-210 is a way of similarly delivering intravesically erdafitinib instead of chemotherapy directly to the blood via silicone tube, which is positioned just similar to TAR-200. TAR-210 data are related primarily today to the first-in-human trial that enrolled multiple cohort of patients with NMIBC, high risk papillary tumor in cohort 1, or intermediate risk, lower grade tumor in cohort 3. Low grade tumor are very much enriched in FGF receptor alteration, like 60 to 70% of the patients harboring any kind of suitable FGF receptor 2 or 3 mutations or fusions. And the data, very preliminary, that have been provided today, this is the latest update provided at the AUA last year, supported a benefit maintained at the long run in the few patients for which we did report data at the intermediate to long-term run, with a 90% estimated 12 months relapse-free survival rate in the cohort 1 with high-risk papillary tumor. This is for intermediate risk, same situation, quite compelling, although preliminary duration of response data. And the good point here is that we have to limit substantially the side effects of erdafitinib, because you see the concentration here, systemic concentration of the FGF receptor inhibitor when delivered intravesically as compared to the oral administration. That makes quite a big difference in terms of safety and tolerability. And you can see here that the rate of side effects and kind of side effects provided in TAR-210 trial, first-in-human trial, are pretty much similar to those reported with TAR-200. Moonrise-1 is a phase 3 study that is currently testing patients with intermediate risk non-muscle-invasive disease to receive TAR-210 versus intravesical choice, investigator choice intravesical chemotherapy. Primary endpoint is disease-free survival. Another key trial ongoing is the Moonrise-3, which is currently randomizing patients who have been already who have any kind of T1 disease or TA disease or recurrent after BCG, so allowing prior exposure to BCG, again to receive TAR-210 versus intravesical chemotherapy. Disease-free survival, another primary endpoint. These could be another 2 studies with the potential of a transformation of the clinical outcomes and the possibilities. So we have already mentioned that the rates of CR reported in the various clinical trials, and we have already in particular reported the focus on intravesical therapies has been the key as compared to systemic therapy with regards to durability, 6 months or 12 months of responses in this particular patient population. BCG unresponsive disease is still, BCG re-challenge is still an option in the real world. I don't know what is your experience, but in fact, in the real world, there is a way of re-challenging a few patients with BCG unresponsive disease, getting some kind of responses again. And finally, I will open up the door to the point that we have touched before with regards to the availability of the drugs. Today, for the same patient diagnosed in the United States or in Italy, the situation with regards to the availability of treatments is pretty much different. So there is a huge geographical disparity. And finally, we are moving intravesical therapies with a bit more advanced patient population with the muscle-invasive disease. We do have data from Sunrise 4, TAR-200 and sertralimab in the neoadjuvant setting prior to cystectomy, and we will hear tomorrow the result of the combination as compared to chemoradiation in the same patient population. So the conclusion already included in the presentation. I think that the last bullet point is the most pressing one for patient advocates, a patient population that is observing such a huge disconnection between opportunities in the opportunities for newer therapies between continents, and between geographical regions. Thank you.
Excellent. That was a great overview. Really a lot to cover in a very short time. We could probably spend a whole session just talking about those topics. So let's move to the discussion between Dr. Love and Dr. Plimick.
The Phase 3 Keynote 905 EV303 study of neoadjuvant enfortumab vedotin plus pembrolizumab in cisplatin-ineligible patients with muscle-invasive bladder cancer presented at ESMO, and the Phase 3 Keynote B15 EV304 trial of EV-Pembro in cisplatin-eligible patients being presented tomorrow morning at this conference are rapidly shifting the treatment landscape for localized bladder cancer, as evidenced by Dr. Plimick's clinic the day I spoke with her.
I met a patient just today who came to my clinic with a diagnosis of non-muscle-invasive bladder cancer starting about a year ago. He actually elected not to go through with BCG and was monitored with repeat TURBTs. 2 more showed non-muscle-invasive disease, but most recently, the biopsies showed muscle-invasive disease, no lymphovascular invasion. Imaging showed mild hydronephrosis, no evidence of metastatic disease. This patient was 80 years old. He was cisplatin eligible. No major medical comorbidities other than hyperlipidemia and obstructive sleep apnea. I recommended, even though he's cisplatin eligible, enfortumab vedotin with pembrolizumab. We talked about cystectomy versus treatment on our bladder preservation clinical trial, where patients with a clinical complete response can avoid cystectomy and go on to active surveillance. After a long discussion and his stated preference to keep his bladder if possible and to not go through a big surgery at the age of 80, he enrolled in the clinical trial. So I'm curious, what would you have recommended to this gentleman if he were in your clinic? Here in our practice, we've started using EVP as neoadjuvant therapy for cisplatin-ineligible patients since the ESMO presentation, but truly also for cis-eligible patients, we're still using it. I'm curious, what's your practice with EVP? I actually find in my practice giving the 3 cycles of EVP in the neoadjuvant setting is easier in many ways to get through. I think a lot of the neuropathy doesn't evolve until later, so we get away without that. I'm curious if your practice reflects that or not.
Great. So also a lot to unpack here. So we have an 80-year-old patient who develops MIBC after having refused a lot of the therapies we just talked about for NMIBC, for non-muscle invasive, and now wants to avoid cystectomy, which is very reasonable considering the morbidity of cystectomy. So EVP is available as of today for patients who are cisplatin ineligible. We've already heard from Dr. Gupta about a press release and the data that Dr. Galsky is going to present tomorrow for cisplatin eligible patients for EVP. That's a positive study. Have you, let me ask you, Dr. Gupta, have you been integrating EVP for cisplatin eligible patients already, or are you waiting for tomorrow before you'll
I am waiting for tomorrow.
Interesting. Can you say more?
If the patient is refusing chemotherapy, then yeah, we are.
Was it just a feeling that we didn't have good data yet on the value of EVP in the cisplatin eligible group?
I think just being a purist, waiting for the data, because we do have options for these patients. There's Gemcis, durvalumab, and also we had a clinical trial also where they were getting EV-Pembro as a perioperative with the vaccine study. So we had options.
Okay. And Matt, so you have had a large role in the EV304 trial. Were you using that regimen off trial in a patient, for example, like this?
Yeah, I would consider it, and I have. I think Dr. Gupta's response is obviously quite appropriate. Being a purist, you'd wait for the data. We have informed patients who come in and want this treatment after having heard about the ESMO data, and I think it's reasonable to discuss it, particularly because that trial included patients who declined cisplatin-based therapy as well.
Do you think there's an ideal patient who should get EVP? We have data now for cisplatin ineligible MIBC. Tomorrow we're going to hear about the data for cisplatin eligible. Is there a biomarker? Is there someone, some way we can determine who might benefit from platinum? For example, variant histology. Do you find that there's a rationale to maybe avoid EV and still give them platinum? Or are there other subgroups or types of bladder cancer that you have more sort of thoughts about, concerns about?
Yeah, I mean, it's the patients with variant histologies that I scratch my head about the most. And there's been a number of publications looking at nectin expression, either at the gene expression level or at the protein level, recognizing that the studies looking at it at the protein level aren't necessarily using the proprietary assays that have been used in the clinical development program. In patients with variant histology, and it's a little bit across the board, but some of the variants, there's a high proportion of patients with no expression, and so then you get a little bit worried about whether or not that's the right choice, but otherwise I think it's probably the right choice in most patients.
Okay, so you give it to most folks. Okay.
If I may add?
Yeah, please.
Very, very briefly. It depends also on the radical cystectomy suitability in this patient population. And things have changed substantially, besides the patient desire, but in most of the urology departments, consideration towards radical cystectomy suitability has changed substantially from the urology side. For example, a patient like this will never be operated on my side. Will never be operated because it is high risk of developing side effects, sure. Potentially deadly surgical sequelae. So I would consider personally this patient population as being the best candidate ideally for chemoradiation or radiotherapy alone.
Right, so chemoradiation is an option we haven't really talked about a lot. And I agree with you. I think that's an option. Now, Matt, you led a very important study looking at preserving the bladder in which patients got neoadjuvant platinum and a PD-1 inhibitor. And then if they were in a strict clinical CR, they were allowed to keep their bladders and be monitored closely. And there was just a recent update. Do you think that an EVP is, first of all, tolerable, as the question here asks? And then do you think there's a role for giving EVP and then monitoring patients very closely, as that was done in this Hoosier trial, and allowing them to keep the bladder, especially in someone who's 80 years old and may have competing comorbidities?
So that's the trial that this patient was enrolled on, was EVP with potential for no cystectomy in patients who have a clinical complete response. And I think it's reasonable to do right now in the context of a clinical trial. I don't think this is ready for prime time. This is a departure from standard treatment and has a large amount of risk involved in not doing this right. And so I think we need more data before it's ready for prime time. But I think that's where the field's headed.
Right. And just to be clear, a strict clinical CR involved, correct me if I'm wrong, MRI, cell-free DNA, cystoscopy. Were there other measures that were used?
Cytology, imaging, cystoscopy, biopsy of any visible tumor, or blind biopsies in a template if there was no visible tumor.
Right, so we have to be careful about just giving systemic therapy and not addressing the bladder either with surgery or chemoradiation. In the last 5 seconds, do you think this is a tolerable regimen for an 80-year-old man, EVP?
I think it absolutely can be a tolerable regimen, but like most of our systemic therapy regimens, there's a lot of heterogeneity. So some people fly through it and some people don't.
Right. So it's very individualized. Okay, let's move on to the conversation with Dr. Pauls.
The next patient, presented by Professor Pauls, is a man in his late 70s with BCG refractory CIS.
We gave him induction and maintenance BCG, and during the maintenance BCG, he relapsed with more carcinoma in situ. And so there has been a huge expansion in novel therapies in this space, in the CIS refractory disease. And that has been largely driven by the FDA's willingness to approve drugs off single-arm trials with only 100 patients. And Sunrise 1 was a great example of that. where we gave TAR-200, an intravesical pretzel-like device. It slowly releases gemcitabine over a period of time. We've used a lot of this drug in our practice within the context of clinical trials. The device is novel, not the drug. I think it's fair to say that this intravesical device has probably superseded some of the other therapies which are being explored in BCG refractory carcinoma in situ. There's a Sunrise 3 study, which is looking not at BCG refractory carcinoma in situ, but frontline high-risk disease. And this trial for me is the Jupiter of trials, because if it was positive, it would be a landmark change to a huge patient population. Because unlike the immune checkpoint inhibition, which is associated with 15% life-changing toxicity, hypothyroidism, long-term diarrhea, arthritis, fatigue, these drugs just have local toxicity.
Any questions for the faculty?
With so many treatments available of single-arm trial, is there a preferred treatment? Do they agree with me that if Sunrise 3 was positive, that would be much more transformative than the current situation, which I think is treatment modifying, but not treatments transformative?
Okay, so also a lot to unpack here, and I think a very interesting case. So 70-year-old man who has BCG refractory carcinoma in situ, so non-muscle invasive bladder cancer. And I think, Dr. Necchi, this really gets to the very heart of your talk. You said earlier that the standard of care for BCG refractory disease is to remove the bladder. Now we have, at least in the US, we have TAR-200 available for exactly this patient. Do you have any concerns about giving TAR-200? Would you give it to everybody, or are there patients you might avoid giving it to? How do you think about that?
Well, with regards to tolerability, at least recorded within a clinical trial, the data are very favorable in supporting the use of TAR-200 in this patient population. In real world, there is an accumulating amount of data indicating that docetaxel and gemcitabine, so intravesical chemotherapy, could be another option. The point is that the use of intravesical gemdosi is much less frequently adopted outside of the US, very infrequently used in most of the European countries, for example. But that could be an option. But yes, the TAR-200, as we currently stand, is best positioned. And second, we have data for cretostimogene that are also quite compelling. But again, generated in a clinical trial context that was primarily focused or exclusively focused on the United States. So for cretostimogene, we need a bit more expanded access, a bit more heterogeneous patient population with regards to geographical variability to confirm the initial findings.
And so to follow on that, I think, obviously we're hearing that there's value to TAR-200. We need more data there. Tom talked about the Sunrise 3, which is looking at TAR-200 in the frontline setting, and actually just the same way that enfortumab vedotin and pembrolizumab is displacing cisplatin as our go-to regimen, as our frontline regimen. Do you think there's a real possibility that TAR-200 could replace BCG, and what are the pros and cons of that? Obviously, if it looks much better, that's great. What if the data looks similar? How would you think about this? How would you counsel the patient, also recognizing there's a major BCG shortage worldwide?
Yes, this is the major point. I suspect also that from the urologist standpoint, even though they seem to be quite happy in using BCG, whenever they got any alternative therapy that is effective or more effective than BCG, they will jump directly in this direction, as we did for standard cisplatin-based chemotherapy in the neoadjuvant setting. Whenever we had any alternative option, all of us jumped into this direction. So it depends, as you said, on the magnitude of effect for sure, and the trial should be clearly positive. With regards to the primary endpoint and maybe key secondary endpoints, the BCG is hard to beat, has demonstrated to be very hard to beat in clinical trials. The performance is quite good for BCG. It reminds me of a situation in the MIBC which is similar for chemoradiation. So very hard to beat comparator because in clinical trials the performance is quite good. Let's see. But for sure, I agree with the colleagues that positivity of Sunrise-3 trial will make a huge difference in the way we sequence intravesical therapies in patients with MIBC.
Okay, so much more to come in the frontline setting, and I think it sounds like we're going to need to hear about the efficacy. Maybe toxicity is going to be similar between BCG and TAR-200, perhaps. Dr. Gupta, so FGFR-altered bladder cancer is one of the only truly biomarker-defined diseases we have. There was data that Dr. Necchi showed us about giving oral erdafitinib that seemed to be fairly, toxic in terms of side effects. What do you think about TAR-210? And what I'd love to know is, like, if you have a patient who has an FGFR mutation, do we think TAR-210 is a better drug than TAR-200? Are we actually achieving something by looking for this biomarker and treating, or is it too early to say?
Yeah, I think, FGFR is the only biomarker right now which is truly, we know, that drives the cancers, and we have a therapy for it. So I think oral erdafitinib is definitely very, very toxic, especially in patients with this early stage, and that's why the study was stopped early. And I think the TAR-210 data is really compelling. You're getting the efficacy from the FGFR inhibitor without the systemic toxicity. It's best of both the worlds, in my opinion, and definitely would go for that.
So it seems like it may be an option in the future. I want to emphasize when Dr. Necchi showed the PK, there's like a 2 log-fold less, like 100-fold less erdafitinib being absorbed when we give TAR-210. I guess open up to the panel. Do we think that TAR-200 is going to be inferior in an FGFR-positive population? We don't know. Is there a rationale to sort of develop both drugs? I mean, clearly they are being developed, but how do you think about that? Go ahead.
I just want to add that, in all the other studies with TAR-200, we really don't know what % of patients were FGFR-altered tumors. So it would be good to look at that retrospectively and see how they did and make that decision.
Agreed. Any other comments about, other therapies that we should be putting into this patient population who has sort of high-risk non-muscle invasive, and any comparative efficacy that we have?
Well, we do have the data from nadofaragene that are pretty much consistent with the data obtained with pembro monotherapy. It's a way of achieving similar results by delivering intravesically a drug instead of systemic therapy. So clearly, results that stands as a second option in theory after the results shown with the TAR-200 and cretostimogene that are at the forefront of the development with regards to CR and maintain CR. There could be additional data that soon the data will be presented with newer systemic immune therapy combinations showing that there is no signal for enrichment in CR, but we do have much more toxicity events in this patient population. So the struggle is again in identifying possible new combination therapies that are aimed to minimize a little bit the toxicity that we can provide to the patients with systemic therapies. It's a challenge, but today the primary focus is on monotherapy as intravesical therapy.
Intravesical, right. So this is a disease confined to the bladder. We should probably be giving diseases into the bladder and not exposing patients to all the risk of systemic therapies. At least that's the trial data so far.
Or maybe TAR-200 or gemcitabine and erdafitinib combined into the unique system into the bladder.
Right.
Technology may allow us in the near future to provide multiple therapies the same way.
Right. So there's really a lot of super interesting options. I think it's a great time to be in this field to have so many options. So, okay, we're running short on time. I want to turn things over to Dr. Galsky, who's going to talk to us about circulating tumor DNA. So take it away.
Thank you. So let's talk about ctDNA in bladder cancer. So this is what I think we know right now. This is what I'm going to try and convince you, that ctDNA tells us who needs adjuvant treatment. I put the caution sign on ctDNA telling us who doesn't need adjuvant treatment, and I alluded to that before. I'll explain to you why I feel that way. And then I put the stop sign on ctDNA tells us who doesn't need neoadjuvant treatment. With the current assays that are available, I don't think we're there yet, and I'll show you why that is. So I think, first of all, it's important to recognize that this is not a new concept. CFDNA was actually identified in a paper in 1948, And so we are truly standing on the shoulders of giants when we talk about this technology basically taking over our field. This is not developed overnight. And the sort of one of the landmark papers in terms of MRD from a ctDNA standpoint, monitoring patients after definitive surgery from Bert Vogelstein, Luis Diaz, that was 2008. So it's taken a while to get to this point, but now, of course, this is impacting pretty much all of the treatment decisions that we face in bladder cancer. The technology that I'm going to refer to in my slides is the Signatera technology. Why? Because that's where the vast majority of data has been generated in bladder cancer. We have smaller data sets with other assays, but this is where we have the bulk of data. So to remind you, this is tumor-informed ctDNA testing, whole exome sequencing in the primary tumor, identifying up to 16 alterations, designing a bespoke PCR-based assay to check for those alterations in the plasma, and then determining whether or not one can find those in the plasma as a measure of minimal residual disease. So Dr. Gupta showed this slide before. These are the 3 adjuvant studies that we have with immune checkpoint blockade. I'm not going to go through them in detail, other than to say that IMvigor10 didn't meet its primary endpoint. The others did. The fact that that didn't meet its primary endpoint had led the investigators to really ask why, and that really has opened up the field of ctDNA testing in urothelial cancer. There were some smaller studies prior to the retrospective analysis of IMvigor10, but this was the largest study of ctDNA testing in the setting of a randomized clinical trial, and I think really made ctDNA testing something that we were really thinking about in terms of all of our studies moving forward after that data was presented. So what's the value proposition of adjuvant therapy? This is probably stating the obvious, but this is the adjuvant data for nivolumab in patients with muscle-invasive bladder cancer that Dr. Gupta already showed, right? In the gray is the placebo arm, the green is the treatment arm. And so, of course, you know that looking at these curves, those patients don't need adjuvant treatment. You could give all those patients all the adjuvant treatment in the world. You're not going to help them. You can only harm them because they've already been cured with surgery. Those are the patients who are benefiting from adjuvant treatment. And these patients are getting adjuvant treatment, but they're not benefiting from treatment. And so they need potentially a different adjuvant treatment. So this is the value proposition. We give adjuvant treatment to everyone to try and help those patients in orange there. And obviously, this is not a precise way to employ a systemic treatment. It's just that we haven't been able to do this in a more rational way in the past. And so we have this double biomarker dilemma in the perioperative setting. In solid tumors, that's a little bit different than the biomarker dilemma that we have in the metastatic setting. In the metastatic setting, arguably everyone needs treatment. We just don't know what drugs to give which patients. We don't know which tumors are most sensitive to which drugs for the most part. In the adjuvant setting, we have a double biomarker dilemma. Not only don't we know who benefits from which drugs, we actually don't even know who needs treatment. And these are sometimes conflated, but they're actually separate concepts and might require different biomarkers. They get conflated because you can't benefit from a treatment if you don't need a treatment, but you could need adjuvant therapy and not benefit from the particular drug that's being given, as I showed in the prior slide. So we need biomarkers to inform both. Biomarkers to define who benefits from a particular drug are a little bit more challenging, but biomarkers to define who needs treatment in the adjuvant setting, I think that's here with ctDNA, and I'll show you the data to support that. So this is the retrospective data from IMvigor10, disease-free survival curve, overall survival curve. What you're seeing here is ctDNA testing using Signatera at a single time point after definitive surgery. And then the curves are stratified by patients with undetectable versus detectable ctDNA, and then the blue is atezolizumab, and the red is observation. So you can see here that the patients who had detectable ctDNA post-surgery are the ones who seem to be benefiting from atezolizumab, those bottom curves. The top curves, it's a little bit harder to see a difference between those lines in patients with undetectable ctDNA. Of course, that's what you would hope to see, But I'll remind you that looking at these curves, the patients who have undetectable ctDNA, not all those patients are cured. There's actually a pretty high risk of recurrence there. So saying that patients who have undetectable ctDNA don't benefit from adjuvant immune checkpoint blockade, if that's the conclusion, is not the same thing as saying all of those patients are cured with an undetectable assay after surgery. And I think that's where we have to be a little bit more cautious. The other thing about ctDNA in this context, of course, is that this opens up a whole new space for drug development in this setting. Historically, we've taken the drugs that work in the metastatic setting and just moved them to the perioperative setting. And we do that for practical reasons because you can't do a phase 2 study in the adjuvant setting because there's nothing to measure except time to event endpoints, and then you have to do huge randomized studies, right? But with ctDNA, you can look for clearance of ctDNA as an intermediate endpoint and potentially screen novel therapies in this space without doing huge randomized studies, and potentially bring mechanisms that might make sense in the adjuvant space, like drugs that are anti-metastatic. So this data here from IMvigor10 shows that in patients who have clearance of ctDNA on adjuvant immune checkpoint blockade, have much better disease-free survival and overall survival than patients who don't. It's sort of intuitive. You would expect to see that, but it does reinforce maybe this is a tool for drug development. Very similar data now with Checkmate 274 using Signatera. So let's go to IMvigor11 because that's the prospective data that we have. So IMvigor11 designed very similarly to IMvigor10, which I showed you already, but restricted to patients with bladder cancer, no upper tract disease. These patients had high-risk pathological features. After surgery, they had ctDNA testing. If they had detectable ctDNA right away, then they were randomized to atezo versus placebo. If they had undetectable ctDNA, then they were monitored with testing every 6 weeks for a year. And if they converted from undetectable to detectable, then they entered the randomization at that point. Now, the data, the statistical analysis plan for the study pooled patients with detectable ctDNA regardless of when they converted. And so that's the primary analysis. Does atezo benefit patients with detectable ctDNA? But you might separate patients with detectable ctDNA right after surgery versus those who had conversion later on. Those are sort of two different decision-making time points. And so because of the way that the data is presented in the paper, it's a little bit hard to get at what's the risk in a patient with undetectable ctDNA truly of waiting. And so if you look at the consort diagrams, here's sort of what happens. So if you have undetectable ctDNA on that first post-op test, there's about a 22% chance of converting to detectable ctDNA, not unlike what I showed you from the IMvigor10 retrospective data. And about 5 to 10% of those patients developed metastatic disease before their ctDNA converted to detectable. So when we say patients are safe with a single post-op ctDNA undetectable test, there is certainly a risk that those patients will develop metastatic disease. And really the question is, can you benefit them by earlier versus later immune checkpoint blockade? And that's what we don't know for sure. So here's the data with atezo versus placebo separated by patients who had ctDNA detectable tests right after surgery versus on subsequent testing. And you can see that there's a DFS benefit and an OS benefit regardless of when you start atezo. What we don't know here on the bottom, though, is are outcomes in that patient population non-inferior to everyone getting immune checkpoint blockade right after surgery. The study was not designed to address that, and so it can't answer that. This is the curve that's shown very commonly, and this is what happens in patients with serial undetectable ctDNA testing. These patients have a very favorable disease-free survival and overall survival. The problem is that when you meet a patient a month after surgery, you don't know that their ctDNA test is going to be negative a year later. It's sort of like saying if your scan is negative for a year, you're going to do well. Well, yeah, that's sort of obvious. So I think this is very encouraging data in terms of being able to monitor patients. And if ctDNA is serially negative, patients do quite well, but we don't know for sure because of that risk of conversion that treating patients when they develop molecular recurrence is non-inferior to treating them immediately after surgery. And those are the take-home points that I just went through. So there is a study that's being done through the U.S. Cooperative Group system now, trying to address that question of whether or not if you have an undetectable ctDNA test after surgery, whether or not starting immunotherapy right away is non-inferior, or rather whether or not surveillance is non-inferior to starting adjuvant immune checkpoint blockade right away. And then in patients with detectable ctDNA here, there's an escalation arm, which is doublet immune checkpoint blockade versus single agent immune checkpoint blockade.
Great. So thanks for that talk. I do recognize we're running a little short on time, so we want to get to the discussion between Dr. Love and Dr. Plimick, but an excellent talk. So why don't we proceed?
I asked Dr. Plimick to come up with a common clinical scenario to present to the faculty where in the future, or maybe even now, ctDNA may have a useful role.
Here's a scenario of a patient who presents with T4 disease with pelvic pain and pelvic wall involvement, in addition to maybe a lymph node that's 2 centimeters in the pelvis. You treat them as metastatic initially with EV and P, but after 6 cycles, they have a complete response on their imaging. Is this a patient that you would refer for surgery to consolidate the response? Or is this the patient that we accept as being already metastatic, enjoy the complete response, and hope that that is durable without surgery? It's a tough case. We see that all the time.
Okay, so you have a really challenging case. So a patient presents with T4, N maybe 1 or N2 disease. So this is very locally advanced, very high risk of metastatic disease and ultimately dying of bladder cancer, who starts on EVP, as we're talking about in these different EV304 or EV303 trials, has a really excellent response. So Dr. Gupta, have you had a patient like this? Who's had a really excellent response to neoadjuvant therapy? And we sort of talked about this before, bladder preservation in this patient. Is there a role for surgery? Would you recommend a cystectomy now and a lymphadenectomy? Or would you kind of monitor this patient and recognizing that some patients will actually, maybe even get cured with upfront immunotherapy plus minus the EV?
Yeah, so this is a locally advanced patient, like you said, and I think patients who achieve a CR really do well long term, and we've seen that follow-up data from EV302. I really don't think that there is a role for consolidative surgery. That whole concept comes from decades ago when we had no systemic therapies which were really reasonable. And I think pushing that in the era of such effective therapies and also effective biomarkers is really an overkill.
Right, so maybe too much, because it is, as we've been saying, surgery is tough for many patients. Dr. Necchi, do you think there's a role for cell-free DNA monitoring here, to consider them sort of having metastatic disease? And I guess what would you do with the cell-free DNA data? If it came back as negative and turned positive, would you do anything different?
Well, if you start from the assumption that surgery has no role, as I would start with, as Shilpa has mentioned, so we don't have any single data suggesting that surgery may play a role in this patient in improving some kind of interim outcomes of survival in this patient population. So if starts from this assumption, then the role of ctDNA would not be so impactful in the decision making as compared to standard imaging tools. So in patient with the CR, when it is slated to continue systemic therapy, I think that there is, as of today, no way of thinking differently with the use of biomarkers. Let's see in the future when we will have possibly newer systemic therapies that can be used in sequence. That we can discuss about the opportunity to shift from one treatment to another based on ctDNA positivity or positivization. But as of today, the impact is limited.
Right. I think it's important when we think about cell-free DNA or ctDNA is to think about it as a tool. Right, and you have to use the right tool for the right problem or the right question. And so you can look at it as a prognostic marker to tell you who's going to do poorly, who's going to do well. You could think of it as a predictive marker for who's going to benefit from therapy. And I think Dr. Galsky talked to this a little bit. You could technically use it for discovery to find, other circulating mutations. Do you think, Matt, we're trying to ask too much of cell-free DNA, or are we sort of proceeding in a logical way with this?
I think the right questions are being asked, and it is incredibly helpful to see that studies are being designed to assess clinical utility rather than just relying on retrospective studies for decision making. I think that the field, despite the widespread use, I think in terms of really informing decisions, the field has been pretty thoughtful about trying to design the right studies. I'll say, just as an aside, even though I am strongly in favor of trying to thoughtfully develop approaches that use response in an individual patient to decide whether or not we could de-escalate treatment, there is some correlation between baseline burden of disease and the likelihood of quote-unquote sterilizing disease with systemic therapy. And if there is a window of opportunity for cure, I think it might be with surgery in a patient like this. So I would talk to this patient.
You might push a little harder.
Yeah.
Would anyone push for chemoradiation or radiation alone in a patient like this who's had an excellent response to EVP, perhaps wants to keep their bladder? Recognizing we don't really have data in that context.
And it depends what the bladder is showing. And if it's showing non-muscle invasive disease, I actually have a patient like that, and she's been now disease-free in the metastatic sites for over 4 or 5 years and has NMIBC, and we are tackling that with intravesical.
Right. We have a patient who was on the EV-103 trial who got EVP, had eradication of all the disease, and 3 years later developed an NMIBC, which I think was a new tumor, and actually responded really well to BCG.
Yeah.
So I think there's a lot of different ways we can think about this disease. Okay. And do you think that the ctDNA test in this patient we've been talking about, Matt, that it would change your approach to monitoring? So if they turn positive, you're going to get a scan much quicker, or is there other ways that you're going to use this?
Yeah, I would certainly do scans earlier if this patient had detectable ctDNA. In this context, with regards to the surgical discussion, I would really feel much more comfortable if that patient had undetectable ctDNA before I recommended that they undergo a major surgery.
Yeah. Okay, let's do this. This is our last video, so Dr. Poles again and Dr. Love.
I also asked Professor Pauls to describe a case where circulating tumor DNA may have a useful role, and he described a 72-year-old man with muscle-invasive bladder cancer, status post-neoadjuvant chemoimmunotherapy.
He is a patient who has muscle-invasive bladder cancer. He had neoadjuvant chemotherapy with durvalumab because it's pre-EV Pembro era. We used the Natera approach to track his ctDNA. This patient was positive pre-surgery. We gave him treatment. He then remained positive pre-cystectomy. We then performed surgery on him, and we transferred him from being positive to negative post-surgery. He had not had a pathological complete response. But now he's CCA negative. And so my question to the panel with this case is, do you think we should stop therapy, or should we keep going?
Any other questions for the faculty?
I'd like to ask the panel whether or not they feel urinary tumor DNA in parallel with circulating tumor DNA are going to be used together.
I have not heard that one. Urinary ctDNA? Wow.
You could use UTDNA and ctDNA in parallel. And Neil, there was some data from the Sunrise program at ESMO this year that correlated UTDNA with pathological complete response. Almost all patients are UTDNA positive at baseline. And then what essentially happens is there's clearance in about half of those patients with different approaches. And that clearance correlates with pathological complete response. So we're beginning to get a clear signal. And I can tell you at ASCO GU, there are a number of different posters and presentations looking at UTDNA, including one from the Niagara study, which Matt Galsky is also involved with, on UTDNA in the Niagara trial.
Okay, so this is a 72-year-old man who got neoadjuvant chemoimmunotherapy, platinum for durvalumab, was positive with cell-free DNA until after surgery and then was negative, didn't have a complete clinical response. So, I think Matt, we've already heard you say this a few times that the negative ctDNA result we have to be careful about, whereas a positive one is maybe more actionable. I guess, does that change if somebody's had a complete pathologic response and they're cell-free DNA negative at the time of the post-op visit?
It doesn't, but I think the context is really important, right? So that's a slightly separate question than this patient. This patient didn't clear with systemic therapy, cleared with surgery. I'm really worried this is going to be a very transient clearance, and months later, this patient's going to have a detectable ctDNA. Now, whether or not continuing durva in this setting is going to impact that, it's hard to know, but that's the way that the treatment was given on study, and that's what led to the benefit on study, and so I think it's hard to deviate from that in the absence of data. To your question, if a patient had a path CR in negative ctDNA, obviously, the thought is that maybe that patient doesn't need additional treatment. The problem is that we also don't have that data. And when you look at patients with undetectable ctDNA from Niagara, those patients still benefited from being on the experimental arm. And we don't know if that's driven by the neoadjuvant or the adjuvant portion. But in the absence of the third arm that didn't give the adjuvant portion, that's unanswerable from that trial. So at the present time, in being a purist and sticking to the evidence, you would continue treatment.
Right, so I think what you're pointing out is some of the sort of dissatisfaction with these sandwich approaches where a lot of therapy is given before and after therapy, before and after surgery, where we don't have a contribution of the components. And so hopefully we'll see that in future studies, but that's going to take a long time. So, I think we've talked about this a lot, cell-free DNA or circulating tumor DNA informing practice. Do you think medical oncologists, and maybe Dr. Necchi, do you think medical oncologists should be ordering this? If this was available in Italy, would you recommend to other oncologists to order this in the perioperative setting?
Well, in principle, knowing that the prognosis of the disease in an optimized way by integrating ctDNA into the tools to which we could assess the patient is good. So first of all, when you start treatment, and you have to inform your counseling with the patient, providing the information on ctDNA, so the possibility to be cured at the end of the day from their disease is important. So it's important for patient counseling. And also, it's important for, as we have discussed, for monitoring of the response to treatment. It's less important, based on the Sunrise 4 data. It's less important if we foresee any opportunity to skip radical cystectomy based on these results. And here it comes the opportunity to integrate with some kind of local assessment, like UTDNA. And UTDNA is pretty well better positioned than ctDNA in predicting the fate of the tumor into the bladder wall. And so for projecting ourselves to the next generation trials and the newer opportunities that maybe result in newer therapies tomorrow, when it comes to the opportunity for the patient to skip radical cystectomy, I would be very much more favorable to pursue this opportunity in patients with ctDNA negative test and the UTDNA negative test.
Great. So it seems like UTDNA, urinary tumor DNA, may have a potential for us to understand how the local disease is being controlled, and circulating tumor DNA may have a potential for the systemic therapy. Okay, so I think we are just at time. I want to say thank you so much to our panelists. I thought that was a really great discussion. So much to discuss here, and there's so much more we're going to learn. There are major presentations tomorrow, both by Dr. Galsky and Dr. Necchi, so please attend them in person or virtually. And with that, I'm going to say thank you, have a very good night, and have a great rest of the meeting.
Thank you.